In mid-March, the deadly threat presented by this COVID-19 situation required all hands on deck and the decks to be cleared, so to speak. That is, not just elective surgeries were put on hold, but major surgeries for cancer and heart disease also had to wait until we flattened the curve. As we approach that moment, is it time to get all these other things going again? Let's ask all of them in the provincial capital tonight. Peter Weltman, Ontario's Financial Accountability Officer. Dr. Danielle Martin, Chief Medical Executive at Women's College Hospital and a practicing family physician. And Alison Thompson, Professor of Public Health Ethics at the U of T's Leslie Dan Faculty of Pharmacy and the Dalla Lana School of Public Health. And it's great to have you three on TVO with us tonight. Welcome to the attic, so to speak. And I want to read just a little excerpt from the FAO's report, the Financial Accountability Officer's report, and I'll read these numbers out for those listening on podcast who can't follow along. The FAO tracked a period from March 15th to 5 weeks later, April 22nd, and discovered that up to 52,700 hospital procedures have been canceled or avoided. And every week that the COVID-19 outbreak continues and monopolizes our hospital time, I guess, up to 12,200 more procedures are delayed. Now, Peter Weltman, let's just consider those numbers. That's over a 5-week period that you surveyed for this report, but of course we're beyond the 5 weeks now. So can you amplify that a bit? What's happening to our hospital system each week that we wait to get regular surgeries back in the queue?
Well, I think what we discovered up until that point was you have to put off 12,000 odd elective surgeries. The reason we started this report was basically at the request of an MPP. And it was sort of our questions too, is that we've heard a lot about hallway healthcare. We've heard about hospitals are running at overcapacity. And then we hear, oh my gosh, we have to try to find spare capacity in our hospital system to deal with a potentially significant wave of COVID infected patients. How is all that going to happen? And that's why we did the report. And the report lays out sort of what the starting point was, some of the measures that were taken in order to free up space, some of the money that was available to be spent to move folks out of hospital beds and into different types of beds. And as part of all that analysis, we looked at the whole cancellation of elective surgery piece, and that's when we came up with that number.
Danielle Martin, I should, I guess to set up this next question, I should remind our viewers that I guess it was about a week and a half ago that Health Minister Christine Elliott allowed in one of the Premier's daily briefings for the fact that the University Health Network had done some modeling on this, and her estimate at the time was that 35 people had probably died because they didn't get the surgeries that they needed. And you could almost hear the collective gasp from other ministers and members of the media who were listening in on that reveal. In your daily practice, do you see the consequences of people having their surgeries delayed?
Of course, we see those consequences all over the healthcare system, and it's not just from delays in surgeries and procedures, it's also from delays in access to diagnostic imaging, canceled and delayed specialist appointments, and difficulties accessing primary care. So, on the one hand, it was, of course, necessary to prepare for the worst case scenario in terms of the COVID-19 surge. And that did involve ramping down in many cases to only the most urgent and critical functions in our healthcare system. But on the other hand, that's got consequences. And so we're now, all of us, really struggling in the hospital sector with figuring out how do we get the right balance between the ongoing needs, the backlog that's now been created as a result of these difficult choices that had to be made, and then, of course, the ongoing requirement for COVID-19 capacity into the future, because as we all know, even though we're talking about very slowly and gently reopening our economy, this pandemic is not over. And so there's going to be an ongoing need for healthcare resources to serve patients who are getting sick with COVID. And so all of those are really important factors.
Alison Thompson, I wonder if you could pick up the story with the words that we just heard Dr. Martin utter, which were those decisions that had to be made let's just understand that. Did, in fact, the healthcare system and all of the stuff it normally does, did all of that, in fact, have to be put on hold so that we could absolutely, utterly, singularly focus on COVID-19 and making sure we had enough beds and respirators and so on and so forth?
Yeah, that's a great question. And of course, this is a perpetual problem for public health in that, when we do things properly, nothing happens. And so um, I think this is one of the challenges about the optics of all of this. But what would have happened if we hadn't done this and then we ended up with a situation like they're facing in New York City? I mean, that would be uh, probably far more collateral damage than what we're seeing now, which is not to say that there aren't harms created by creating that surge capacity in the system. And it's a matter of prioritizing, choosing which harms we're going to be able to live with. And I don't think it would have been responsible to not plan for a massive surge. So these are really difficult problems that people face in terms of picking priorities.
But let me get you back on this one, Dr. Martin, and that is, if somebody dies of COVID or somebody dies of heart failure because they didn't get the bypass surgery they were waiting for, at the end of the day, somebody's dead. And how does healthcare, and I put that in inverted commas, decide who gets to live and who gets to die under those circumstances?
Well, I mean, the reality is that we haven't completely stopped delivering healthcare in Ontario. Our hospitals are not at 100% capacity, but many are at 60, 70, 75% capacity. We're still doing essential surgeries. We're doing fewer surgeries than we used to do. And most of the surgeries that have been delayed or canceled fall into the category of elective surgeries. So that's not to say that people don't suffer as a result of having their surgeries canceled or waiting, or that we never make a wrong call. But cancer surgery is continuing to take place. Heart surgery is continuing to take place. So I don't want to leave people with the impression that we've kind of, shuttered the hospitals and locked the doors and walked away. And at the same time, bringing people into the hospital to do non-emergency or non-urgent surgery is also a risk to those people themselves. So you can imagine, what would it mean to bring in a frail senior who needs a hip or a knee replacement, and for that person to then contract COVID in the hospital because we've got, crowded hospital wards and lots of people in a scenario where it's not possible to do physical distancing. So what would happen if a patient came in with COVID and passed a healthcare worker who then passes it to many more healthcare workers and patients? So we're doing our best to try to balance safety of the public, safety of the healthcare workforce, and be kind of prepared to take whichever blows come first. And I think we're never going to get it exactly right, but it's not as simple as just saying, oh, well, either somebody dies of COVID or somebody dies of heart failure. What we're trying to do is as much of the critical and essential work as we can, and also hold back on some of the more, we'll call it routine or elective care. The difficulty is, of course, you can do that for 4 weeks or 6 weeks, maybe you can do it for 8 weeks, but at some point, the demand starts to get overwhelming and we're going to have to deal with those backlogs. And that's when some of the really tricky conversations and trade-offs are going to start to take place.
And we'll get to a bit of that discussion. But as long as I've got the numbers guy here, Peter Weltman, let me bring you back in and to that Financial Accountability Office study that you guys just did. And I'll read out the numbers for those listening on podcast who can't see them. And forgive me, everybody, we're going to inundate you a little bit with numbers here, because here's a chart. Actually, Peter, this is your study, so maybe I should have you take us through this, because you were trying to get a sense about occupancy rates in the province of Ontario in our 141 public hospitals. Do you want to just take us through this chart?
Sure. So we looked at what is the capacity. So we have roughly 34,000 hospital beds in the province. And then of those, acute care beds, which are folks that need care right away, roughly 10,000, of which critical care, or is also otherwise known as, those that go into intensive care, we have roughly 2,400 and that many ventilators. And then we looked at the infection rates and how many beds are being used by COVID-19 patients to calculate the remaining beds available for future for alternative uses or future COVID patients.
So as it turns out, if we look on the the old expression, the bottom line, we have thousands of available beds remaining. And beyond that, the province, in anticipation of this COVID crisis, added more than 9,000 acute care beds, added more than 2,000 critical care beds, and 2,000 more critical care beds with ventilators. So I guess the question I want to ask is, how did we get from what looked like we were going to be inundated by this to actually having a very goodly amount of capacity to deal with this?
Well, I think two things really. One was the rapidity or the flexibility shown by the healthcare system to be able to rejig things in order to free up beds. But secondly, and probably more importantly, was the state of emergencies, the social distancing measures that really put a stop to or slowed down the rate of growth. And we did a scenario in the report that showed that had the province waited 5 extra days to implement its state of emergency and its lockdown measures, we would have had a 4-fold increase in the number of COVID infected patients and potential usage of these critical care beds.
So we done good, I guess, is the way we can put this.
Well, I think we looked at the experience in Italy and in Spain. In Italy, they started locking down. I think it was, we were looking at 15 cases per 100,000. And in Ontario, we started locking down at about, we have a report, 3 cases or so. So we started sooner relative to other countries because we had the benefit of watching to see what was happening over there. And I think we reacted accordingly. And, as was pointed out earlier, it's hard to know just how much capacity to create in the system when there are still so many things that are unknown about COVID-19 and the way that it affects people and the way that it infects people.
Having said that, Alison Thompson, how much pressure do you think the healthcare system is feeling right now to, quote unquote, get back to normal, start catching up on the stuff that hasn't been happening over the last 6-7 weeks?
I think that there's going to be a significant amount of pressure to ramp up quickly and to resume, trying to clear some of this backlog. But the real tension there is the ability of the hospital or the primary care office to protect their staff. And so we're still seeing shortages of protective equipment for healthcare workers. We're going to be facing drug shortages. So we need to have some public conversations about how these shortages and constraints on the resources and now this backlog are going to be managed, because we can't ask people to come to work if it's not safe. And, it's also just not a sustainable model if our healthcare workers are going to become ill while they're trying to clear this backlog. So these are really tricky problems, and we've got to balance the health and sustainability of our human resources in healthcare with the demand that's out there. And so it's going to be, a lot of collateral damage, and we have to decide, who's going to bear the burden of that. And so these are really tough conversations that we need to be having, and we need to be talking about how to do that equitably.
When you say we, who's the we?
Great question. I mean, I think that the decision making in a situation like this tends to fall on a very few shoulders. There's sort of a bunker mentality that happens in a public health emergency, but that's exactly the opposite of what ought to happen. And I think we need to be engaging our healthcare workers in conversations about how we can keep them safe, but we also need to be talking to the most vulnerable people in our society about how we can get them access to care in a way that they feel safe, because we are hearing from the disability community, the Black community, and the indigenous communities that, for those groups who have low trust in the healthcare system to begin with, when we start talking about prioritization of certain patients over others, that creates a lot of distress in those communities, and we need to engage them in a conversation about what they think would be equitable. So these are really important ethical conversations that we have to engage with the public on.
I should say parenthetically, we're going to have 2 members of the sort of disability rights community come on our program on Friday and talked about the fact that they certainly are experiencing a disproportionate load of the COVID-19 burden right now. So we will have that conversation on this program on Friday. Danielle Martin, I got to take advantage of the fact that you're here to just sort of get a what's it like on the ground at Women's College Hospital right now. So let me just ask you a few brief questions here. Do you have adequate personal protective equipment there at the hospital?
We do have adequate personal protective equipment, but we know part of the reason why that's the case is because we have so few people coming into the building compared to how things used to be. So our hospital, like most hospitals, looks completely different from the way that it did a few short months ago. We've, closed down to bare bones a lot of our clinical work. We're doing only the most essential stuff. We now have a massive operations in COVID-19 assessment. So we have a big assessment center. We have assessment teams who go out to do swabbing and support in the community, in long-term care facilities, in shelters, in daycare centers where healthcare workers are needed. We've got a big infrastructure support, a set of partnerships with long-term care around supporting long-term care. We've got virtual programs, huge amounts of virtual care happening, not just in my organization, all across the healthcare system, including a program called COVID Care at Home, where we have family physicians who are taking care of patients with who've got oxygen monitors in the home and doing virtual video visits with those people. It's like a completely different place. And so for those who are coming in and taking care of patients and doing surgeries, we do, yes, have adequate PPE. And I think if you were to talk to our staff and doctors, they would tell you that they feel safe. But also, nothing that we're doing looks the way that it did. And I think the reality is nothing is going to look the way that it did for a good long time. And so we are all trying to wrap our heads around what does it mean to do, a goodly proportion of our care via virtual for a long time still to come. What does it look like to have members of our hospital team rotating in and out of working from home as they themselves may fall ill, or just to keep physical distancing and conserve PPE? What are the alternatives to some of the surgeries that we used to be doing? Are there ways that we can support people without having an operation? And the list goes on. And so it's all, and of course, all of these pieces are interlocking, and all of them assume something which you can't assume, which is that we're on the tail end of the downward slope of the curve now, and we can breathe. And in fact, we all know there's probably another, a second wave coming in the fall, if not before. And so everything's going to have to just keep shifting and keep changing.
Well, as we consider the question, let's have this conversation here right now. As we consider the question of how and when to reopen the healthcare system writ large, as opposed to have it being so singularly focused on COVID-19, I'll get the numbers guy in to start off that conversation. Peter Weltman, I presume there is a cost to reopening healthcare. Have you figured out what that might be?
Well, we haven't specifically figured out the cost of reopening healthcare. What we've done, though, is we've done some scenarios, some modeling in a report that we're going to release next week that looks at the economy writ large and looks at the fiscal situation in both what happens if things start to go back to normal starting in June for, sort of over a long period of time, and what happens if we have a second wave and we can't get things started back to normal until January. The economic impact is very significant. I can't reveal the numbers just yet, but it's something we really desperately want to avoid if we can.
When you say very significant, are we talking multiples of billions of dollars?
Yes, we are. Multiples of billions of dollars. Yes.
Serious dough.
Yes.
Allison Thompson, can you tell us who actually is going to be the decider here?
Well, I guess there are a lot of smart people working on this issue, and I have to say that the Ontario government has been pretty good about consulting with the people who will be impacted to some extent, and then also seeking the advice of people with expertise in pandemic ethics. For example, there's a bioethics table that's providing advice to both the ministry and Ontario Health about.
I guess what I want to know is this a political decision or a healthcare decision? Is it the Premier who decides, the Minister of Health who decides, hospital CEOs who decide, Chief of Medical Staffs who decide? Who's the decider?
Right. So I think that we will be hearing from the Minister of Health in the next couple of weeks about what the plan is for reopening and or ramping back up, and that will fall to her. I guess it depends on I guess the hospital CEO is going to have to make some decisions as well about how to do that. But I think that the idea is to provide guidance to healthcare institutions about, how to prioritize which procedures so that we have a fair and proportionate and, responsible approach to this, with the acknowledgement that, we've got to minimize harm here, and that involves some pretty grim calculus about, who's going to get access. And so we can't possibly clear a backlog like this in a short period of time. It's going to take some time, and we need to make sure that we have the resources to do that properly.
Mm-hmm. It sounds to me like somebody's dog wants a say in the matter too. We've had a number of interesting cameos on this program since we all started coming out of our respective homes. Danielle Martin, tell us this. If and when the green light is given to sort of start dealing with the backlog, whose surgeries move to the top of the list?
Well, one of the big and critical questions in this is whose list? Which list is the right list to choose between? And so, the traditional thing would be to say, well, each hospital has its own, its own list, and in fact, each surgeon has their own list, and we just kind of go back to whatever the clinical priority queue looked like before. But that would assume that every hospital is going to have the same resources and the same capacity to start ramping back up. And of course, that's not true. Some hospitals will be harder hit by COVID-19. Some hospitals will have more staff members down. Some hospitals will be redeploying staff. Some hospitals will have less PPE. Some regions will struggle more than others as this thing kind of works its way through the system. And so actually, I believe that the more fair way to make these decisions is to have a regional queue and to have a process for determining what are the most high priority procedures and who are the most high priority patients. And that might mean that the public will have to wrap their heads around, well, originally I was supposed to have my surgery with Dr. So-and-so. That was canceled. Now I've been waiting 6 weeks, and instead now I'm being asked to go to a different hospital and have the surgery done by a different surgeon. But if that's what it's going to take to have a fair and equitable approach, a single queue, a queue for the whole region instead of a queue for each hospital or each surgeon, then I think that's what it's going to take, because we're all going to otherwise be, depending on on chance, essentially, and the extent to which each surgical practice in each hospital is able to prioritize within their own patient population.
Let me do a quick follow-up with you on that, Danielle Martin, and that is, if we're regionally planning these things, should we also be making decisions along the likes of, okay, you two hospitals over there, you're going to get all the COVID patients from now on. You two hospitals over here, you're not dealing with COVID at all. You're only going to be dealing with cancer or heart attacks or whatever. Do we need to do that?
I think we can try to do that, and certainly there are efforts to do some of that, even, to some extent within hospitals. Certainly, there's the designation of COVID wards, and in places where there are multiple hospitals, which of course isn't everywhere in the province, you can try to segregate. But let's remember that there's a huge amount of asymptomatic transmission of COVID-19 that goes on. And any of us could, get it at the grocery store, walking down the street. And so the extent to which it's possible to keep whole organizations entirely, quote unquote, COVID free, I think is questionable. It doesn't mean we shouldn't try to centralize care for patients who are known to have COVID-19. That certainly makes sense. But are we going to be able to say with absolute certainty, well, this institution has no COVID-19 and this institution has all of it? Some of that's going to depend on the way that the virus is transmitted. And some of it, of course, will also depend on the volumes. Let's just remember that a few short weeks ago, we were predicting, based on some reasonable assumptions, that it was possible that every hospital was going to be a COVID hospital and every bed was going to be occupied by a patient with COVID-19. And we are all incredibly, right, we're all incredibly grateful that it didn't, and I hope that it still doesn't. But there are a lot of moving parts to this.
In which case, and Peter, you're going to forgive me for constantly referring to you this way, but you are the numbers guy. And I know the empirically provable data is what's important to you. Do you think we are doing an adequate job in this province of testing, tracing, which is, of course, key to getting a handle on this thing?
So that's not really a numbers question there, Steve, but I'll give sort of
Try to
a
sneak it in.
perspective on it. I'll try to sneak something in there. When we compare testing rates to other developed economies, we're pretty low. You know, Germany's got is at about 100 to working to 200,000 a day. You know, Ontario is around 14,000, I think, maybe 16,000. So if we take those two extremes, we have a little bit of work to do in Ontario. And let's take testing in a broader sense. To understand who's got what, you need to test. You need to know. So this way, you know who's, you know, where your carriers are, where the asymptomatic folks are, where symptomatic folks aren't. Whether you're testing people, whether you're testing anything, that's the only way you know about what's happening on the ground. So I think there's still some work to do if we compare it to some of the other advanced jurisdictions.
There's a great, Professor Thompson, great debate going on in the province right now, of course, as to whether or not people who live in urban areas ought to, in a week and a half, be able to experience the Victoria Day weekend in parts of rural Ontario and quote unquote get away from it all. I want to put that lens on a healthcare situation. Obviously, in the cities, they've just got infinitely more healthcare resources than they do in some of the more rural areas, which explains part of the concern here. How do we consider, when we talk about equitable treatment for all Ontarians, how do we consider that disadvantage that people in rural Ontario and Northern Ontario clearly experience?
This is a really important issue going into the summer. And, you know, we don't want to restrict people's freedom of movement if we don't have to. But, you know, there are regional inequities in Ontario in terms of people's access to care and in terms of capacity. And, you know, you could think about people leaving the big cities in Southern Ontario and going to cottage country as a form of a surge that happens every summer anyway. And then you layer on top of that this outbreak and the fact that those communities, some of them are struggling now with the outbreak, and they don't have large numbers relative to the big cities. But you know, once people from Toronto end up in these communities, they risk spreading it there. And, you know, so in addition to the extra bodies that are now in the region, you're going to have additional risk. So this is going to be a problem that we're going to need to keep an eye on. And I think we need to be talking to those healthcare providers, because they're not going to be able to manage.
Dr. Martin, I got 20 seconds left. You hanging in there?
Hanging in there. Thanks for asking. It's a kind of indescribable thing to wake up one day and discover that there's only one job now in healthcare, which was to prepare ourselves for this. And it's inspiring to see how people have risen to that challenge. And now my worry is that everybody's a bit tired, and now we head into what turns out to be even more complicated work, which is this calibration of the ramp up that we've been talking about, and how are we going to do that in a way that our people can stay resilient to, because it's going to be a long journey.
I don't mean this to sound as trite as it will sound, but you know, we wish you and your colleagues really great good fortune and good luck dealing with this. And needless to say, everybody's counting on you. Good luck, okay?
Thanks, Steve.
Peter Weltman, Financial Accountability Officer for the Province of Ontario, Alison Thompson from the University of Toronto, the Dalla Lana School of Public Health, and Danielle Martin, Women's College Hospital. We thank all three of you for coming on a TVO tonight and sharing your views with us. Be safe, everybody.
You too. Thanks.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.